most of hospital operations is dependent on these glue roles that are highly trained clinical folks who spend greater than 50% of their time just managing day-to-day operational tasks, whether that's hunting and pecking for information out of a system, whether it's data entry into that system, whether it's coordinating via text or phone call or fax even. We could take it a step further and give all of these folks their own little intern that basically takes all the low-level tasks off their plate and get to that promise that we've all been talking about in digital health, which is how do we up-level everybody or get everybody to operating at top of license?
Welcome back to Building with AI, the podcast where we explore how AI is reshaping industries in real time. I'm your host, Haroon Choudery, and this season we're diving deep into one of the most fascinating and high-stakes applications of AI, healthcare. Today, we're tackling a big question, which is how are health systems actually adopting generative AI? We hear a lot about AI in healthcare, how it can reduce administrative burden, streamline operations, and even assist in clinical decision-making. But what's happening on the ground? To answer that, I'm joined by Imaad Rashid, who leads AI Product Commercialization at Qventus, a company at the forefront of AI-driven automation for hospitals. Imaad has spent years translating cutting-edge AI research into real-world healthcare solutions. And today we're going to break down a few things. Where generative AI is making a real impact in healthcare. So going behind the hype. How hospitals are integrating AI into clinical workflows without disrupting care. The biggest barriers to adoption, whether it's trust, regulation, and making AI work for doctors and not against them. And what the future of AI in healthcare might look like. If you're in healthcare, AI, or just curious about how these technologies are being deployed in one of the most complex industries, this episode's for you. Let's get into it.
This episode of Building with AI is brought to you by Autoblocks, the company I founded to solve one of the biggest challenges in AI today, making LLMs safe, reliable, compliant, especially in high-stakes industries like healthcare. If you're a company building AI-powered products, whether that's a virtual health assistant, AI-driven documentation, or any LLM handling sensitive information, you know the risks. LLMs hallucinate, they leak sensitive data, and in regulated industries like healthcare, finance, and insurance, compliance isn't just important, it's the law. So what's the challenge? Most companies rely on manual spot checking and vague governance policies. That's not scalable. What you really need is a way to proactively catch AI failures before they happen. Before an LLM suggests incorrect medical advice or violates HIPAA compliance. That's where Autoblocks comes in. We're an automated QA and compliance platform for LLM products, purpose-built for regulated industries. With Autoblocks, your team can run structured AI evals, detect risks before deployment, and enforce real-time guardrails in production, all while maintaining auditability and compliance. We're already helping companies like Hinge Health, Pelago Health, and others scale AI safely. If you're building AI for healthcare, finance, or any industry where safety and compliance matters, you need to be using Autoblocks. Go to autoblocks.ai to learn more or book a demo today. Again, that's autoblocks.ai, the trust layer for AI in regulated industries. Now, back to the episode.
Imaad, welcome to Building with AI.
Thanks, Haroon. Thank you for having me.
I'm really excited to chat with you and to dig into the great work that Qventus is doing in operating rooms around the country, as well as inpatient facilities at large. But to start, can you give a quick introduction of yourself?
Yeah, my name is Imaad Rashid. I'm the head of perioperative care coordination here at Qventus. Been at Qventus for about 7 years. Started by building our inpatient command center product for hospitals, and then have had subsequent roles of delivery leadership and operational leadership thereafter. Prior to Qventus, worked on the outpatient side, leading product and account management for a company called Clockwise MD that focused on optimizing outpatient throughput. We sold that back in 2016 or 2017 to Warburg Pincus. Prior to that, I had my own company called Blue Check Health, which focused on reducing hospital-acquired infections as well as calibrating radiation therapy machines to be more safe. We sold that as well back in 2014 or 15. And then prior to that is what I'd like to call the dark ages, where I was doing telecom, media, and entertainment consulting for a few years, which was soul-sucking. No offense to any consultants out there.
And just walk through the journey at Qventus so far. Can you describe the journey that Qventus has been on over the past 7 years? And especially what I'm curious to dig into is how that journey has led into the emergence of LLMs.
So it's really been over 12 years. We started off originally basically creating real-time data access for health systems. Back in the early days of interoperability, Data out of the EMR was very hard to get. A lot of folks were making operational decisions on month-old, quarter-old data and trying to project out what may or may not happen and change operations as a result. So the first thing was, hey, we actually can get some of this data out real time. Let's get it out to you. Let's put it into dashboards. And then once we started putting it into dashboards, we got feedback that, hey, it's not, this is helpful to know what happened previously. What about projecting out what could happen in the future? And that's where we started toying with statistical inference, getting into machine learning, things like that to project out, and then surfacing those predictions up in those dashboards as well. And then as we started measuring, hey, you're having access to these dashboards, you're not using them as much, what's going on? We realized everybody loves having the dashboard, but operationalizing them in real time during a day where you spend most of your day firefighting is a tall order, right? And so that's what we took the next step. Okay, how do we start setting up orchestrations around the insights, around the projections? And then the step after that, all right, who does these orchestrations need to go to drive the outcomes that the health system is looking for and get them that timely information, ideally 2 hours before an event happens, 5 hours, 24 hours before an event happens. And so that's where we really started getting into what our platform evolved into today, which is identifying issues, orchestrating actions, and setting up a management layer to make sure all of these things are on track. And we started obviously on the machine learning side with our automation platform within inpatient, EDs, pharmacies, things like that, got into peri-op. And it was really during COVID and after COVID. We had tailored our platform to all of the COVID models, and one of our models was actually used by the White House COVID response team to figure out where to send ventilators, which we're very proud of. But coming out of it, everybody was so burned out that the ask was for an evolution of our platform, which was, all right, hey, we're not sending our people outside of Epic or Cerner or the EMR. EMRs are starting to develop this capability. It's just not a battle us as administrators can fight. And so that's where we actually pivoted our entire model to say, hey, instead of sending folks to an outside platform, Qventus, how are we embedding everything inside the EMR? So all of our orchestrations are happening within the workflow. They don't have to leave what their source of truth is, where they're spending their day-to-day, but they can still get the power of these machine learning models. And then on top of that, because we realized how much everybody was burning out, the next layer started unlocking itself. That, hey, it's not about providing them the insight and the orchestrations to then take the action. How can we take the next step and take the action or some low-level actions on behalf of the care team so that they don't have to do this documentation on their own, right? So that was the next step. Let's embed it in the EMR, but let's take it a step further and let's start auto-filling some of these key documentation steps for patient progression and inpatient, block optimization and outreach on the peri-op side. And so that's where the automation journey really did start, and we started experimenting with it. And now you look at what happened over the last 10 to 12 months with large language models and more specifically agentic infrastructure. And we realized we were very well positioned. We had already started this automation journey with machine learning, natural language processing, and again, just normal statistical inference and deep integration. But these agents allowed us to take it to the next level and say, okay, we know that through our 12 years of experience, most of hospital operations is dependent on these glue roles that are highly trained clinical folks who spend greater than 50% of their time just managing day-to-day operational tasks, whether that's hunting and pecking for information out of a system, whether it's data entry into that system, whether it's coordinating via text or phone call or fax even. We could take it a step further and give all of these folks their own little intern that basically takes all the low-level tasks off their plate and get to that promise that we've all been talking about in digital health, which is how do we up-level everybody or get everybody to operating at top of license. And so that's what we've been working on over the past 12 months or so with our AI operational assistants in the perioperative care coordination space, but then also our block optimization and inpatient solutions as well.
At one point, you mentioned something about clinicians that are burnt out, and obviously this has been an issue for quite some time, and it's an issue that's been exacerbated since the pandemic as well. But for audience members who may not be too familiar with the macro challenge of solving for healthcare worker shortage and burnout, could you shed some light on that issue?
Yeah, so the burnout issue is a very real one. COVID stretched a lot of care providers to their limit. What you saw was not only an increased ask for their time, attention, and heroic efforts. But it didn't come with any upside on the back end for them, right? So you saw a lot of providers that left practicing altogether. We've already been trending towards a nurse shortage. We'll be short about I think 950,000 to 1 million nurses by 2030. So not only is the burnout real because we've been asking them to do more and more without taking anything off their plate. There's actually just not enough of them coming into the workforce to replace the ones that are burning out and leaving to be able to do the work that we've been doing in the way that we've been doing it, right? Very manually, through heroic efforts and with very little automation. Not to be alarmist on this, but physician burnout and nurse burnout is reaching crisis levels here in the US. The main causes are things like systemic organizational pressure. And to make that real, we've asked doctors and nurses to do a lot more administrative work and document a lot more, right? A doctor might see 20 patients in a day, but spend another 3 or 4 hours after work just doing notes and dealing with insurance companies. And this is a doctor that went to school to just take care of patients, not do administrative work, right? We have long hours and staffing shortages. A nurse might work a 12-hour shift and then have to work another 6 hours due to staffing shortages, right? We're going to be short 1 million nurses by 2030, 2035. So that problem is going to become more and more acute. There's a lot of emotional and mental exhaustion for patients who are getting a lot sicker, dealing with a lot of deaths and patient struggles to meet their basic needs. And then this feeling of, I can't do anything about it. And then lack of autonomy, a lot of bureaucratic pressure, right? The amount of time doctors have to spend navigating the health system just to get the right care for their patient. They order an MRI, but they spend an hour on the phone getting authorization from the insurance provider or from the hospital to be able to do that MRI, right? And all of this is leading to poor work-life balance, lack of time to recover, and just there are other options out there now that doctors can go work at startups and have much better work-life balance by being a chief medical officer of a tech company. They can move into other professions. They can retire early. And there was a shortage of doctors and nurses to begin with, so this problem is becoming more and more acute as we go.
Yeah, it is really well said. And so we have this shortage problem, we have this burnout problem, and a lot of folks in the medical space right now are very excited about large language models and the potential that generative AI presents in helping to assuage some of these issues and some of these challenges. Before we dive into how Qventus is thinking about generative AI specifically, I know you hinted at it. Can you maybe describe how the organization thinks about traditional ML versus generative AI? What are the problems that traditional ML models are better suited to solve versus the challenges that generative AI is especially effective at solving?
I could probably talk to it a bit more in the context of how we think about it versus what it should be industry at large. But we're solutions. We take a solutions-based approach to all of our products, right? And so that means choosing the right technologies to be inserted into the right points of the workflow to drive the right business outcomes. And so we see machine learning, natural language processing, large language models as a set of tools in our toolkit to drive business outcomes. So the real question becomes, what's the right tool for the job at hand? So a real life example, risk stratifying patients, right? Stratifying a patient based off their surgical risk and the patient risk. You can do it with discrete data and machine learning models very easily, right? However, the discrete data in the EMR is very often out of date, whether it's the problem list of the patient, whether it's the medications they're on, whether it's the allergies, whether it's a litany of other things. The discrete data isn't necessarily enough information. So what we've done is actually use large language models to read through the clinical notes, not only that are available in the EMR, but also available from outside records, to paint a holistic picture of the patient, use that large language model to turn that unstructured data into structured data so that now our existing machine learning algorithm that was great at risk stratifying patients to begin with is now supercharged with this additional information that machine learning was not going to be able to get out of unstructured data to begin with. So that's an example of how you can use both in concert to drive the outcome more specifically. Now, an example of using large language models more on their own instead of in concert with machine learning would be something like preparing a nurse for a visit with a patient. And so the large language model can not only synthesize what's in the record itself, but synthesize any conversations that the patient has had with the health system via email and any outside records, and be able to tell the nurse that, hey, here are the things that are important to talk about. Here are the risks that the model sees. Here's where in the note those risks exist. Here's the quote out of the doctor's note that you can reference, et cetera. And instead of spending 30 minutes chart prepping for a visit, you can spend 10 minutes doing it because the AI is hunted and pecked around the EMR for you. And that's the large language model doing it more specifically, right? So there's use cases where ML is used by itself. There's use cases where ML is supercharged by LLMs creating structured data for traditional ML. And then there are use cases to use large language models on their own. Does that make sense?
Yeah, it makes a lot of sense. And I like that framing and bucketing into those three different categories. And would you say that generative AI presents more potential than traditional ML when it comes to automating or reducing the amount of time spent on administrative tasks in healthcare?
I think it gives us a step change increase in the ability to do it. Yes. As I started off, we had already started automating via machine learning, right? Writing structured data back into the EMR. What we've been able to do now with large language models, specifically in the form of agents, is being able to deploy these agents to do this low-level administrative work. So think about typing up an after-visit summary for a patient, right? If the AI, the large language model, can listen in to your conversation with the patient, this is something we do, and then synthesize everything you talked about with the patient, the directions you gave the patient, the directions the patient needs for their next visit or for their continuous care. And you were going to type that out manually in MyChart or email after every visit. That was going to take you 10 minutes. Now what we do is the AI synthesizes all that information and you just look at it and correct it. And that 10 minutes has now turned into a 1-minute review and it's sent. Think about getting outside records, right? There are entire parts of health system organizations that are dedicated to nothing but faxing and getting records and getting on the phone and reminding clinics or whoever to get those records back in. Our agents are now automatically faxing these clinics, reminding these clinics. The agent is able to get up on the phone call, navigate a phone tree, and have an agent to human interaction with the HIM department to get these records back. I can't tell you how many times nurses have told me, oh yeah, I sit on hold when I talk to this clinic 5 minutes every time I call. That is 5 minutes times the 10 patients they call a day or meet with a day, right? So these are very real slices of low-level administrative work that are being taken off plates by, that were not possible before agentic AI, right, and before large language models. And so I think we're actually at this inflection point where we can finally realize this promise of, hey, let's get you out of the computers, let's get you out of the technology, let's get you back in front of patients, because we could take the administrative work off your plate.
Yeah, and in theory, there's a ton of potential that generative AI presents in this context. But on the flip side, there's a tremendous amount of unique challenges that generative AI presents across not just healthcare, but any organization that's looking to adopt it and deploy it to a large number of users, especially in regulated industries. And so what are some of the top challenges that a company like Qventus deals with when leveraging LLMs?
The problems with large language models are basically the problems with a brand new technology. There isn't an existing paradigm to do a lot of deployment in a way that scales, in a way that's been done enough times that enterprise health systems, IT departments, InfoSec departments are comfortable with, right? With machine learning, you've had 10 to 12 years, and in some cases, even use cases going back to the 80s of machine learning being utilized in healthcare. So they've had anywhere from a decade to 2 to 3 decades to get familiar with it, understand how to operationalize machine learning safely. And with machine learning, you have probabilistic outputs, right? And it's very easy to say, hey, here are the probabilistic outputs that'll come out. Here are the ways you're doing the unit tests around up. And as long as that is up to industry standards, it's safe. Moreover, with machine learning, there's almost no use case of machine learning that I can think of, and I might be wrong here, that is unsupervised or not human in the loop, right? Usually it's an output that a human reviews that can then either state what it is or be changed to what the human thinks it needs to be. So the unique challenges with large language models and agents is, one, the newness of it all and how do we actually do this at scale safely, but this fear around the fact that, hey, to some degree, there is not as much human supervision as these organizations are comfortable with, especially in healthcare, which is a very sensitive industry, when agents are interacting with clinics or interacting with patients. How do we control that? How do we get as much dependence or deterministic output as possible And the short answer is it's nearly impossible to get fully deterministic with large language models. And so how do we make sure there is enough infrastructure around these agents, that there is that they can be safe, that they are secure, knowing that we'll never know every single possibility that they output, and a human reviewing every one of those, right? Those are some of the challenges at the moment. Now, the great thing is we're now on the vanguard, right? I think this is the first time in my career I was too young for the social media boom in 2007, 2008. I was too young for web 1.0 and 2.0 and the internet. But this is my first go at, hey, we're creating the technology and the infrastructure as it's becoming available, and this is all greenfield. I think that's one of the key things that any operator in this space, if you could create, that is a defensible moat you can create. Is your testing infrastructure robust? Does it drive enough confidence in security departments? And that's where first mover advantage really will matter here in these use cases, that, hey, if you're able to do it across enough health systems that the industry knows that you're a trusted brand around it, you can then scale much more quickly thereafter.
So that segues nicely into my next question, which is if you can describe tactically what the different types of techniques are and approaches are for testing, evaluating, making sure that these systems are safe, and just assuaging any concerns from the health systems that you're selling to.
We are lucky and fortunate that we have some of the best health system partners that we like to call, our clients and partners. As we started creating this technology and operationalizing it, we went to that and said, hey, this is the vanguard. This is what we want to do. Will you help us figure out how to do this together? And so we have 5 of our partner health systems where we are literally, did create this technology with a lot of human oversight. So the first step was, okay, let's create these models. Let's start very small, right? And we even started 10 patients a week, 10 interactions a week, with 3 of our clinicians on staff reviewing every single output that the agent made and approving every single output before it ever made it in front of a human. So it first starts with very rigorous human-in-the-loop testing. And then as we start scaling, what we really have created is I would say, very rigorous testing and validation framework, right? That's single-turn and multi-turn tests. We're using some statistical validation for measuring the AI output, and then also doing red teaming exercises to actually break the AI and purposefully feed it bad input to see how it reacts, and then escalating appropriately. It starts with the human in the loop. I can't stress that enough. Like, anybody who starts without the human in the loop to begin with, I am shocked, and I would ask how you're actually doing it safely. But then making sure that you're setting up that validation framework, and then making sure the escalations are set up as well. Hey, what happens in this instance? When does a human get involved? How does the AI know to get a human involved, et cetera? And I can go into the details of some of those testing frameworks. So there's single-turn tests and multi-turn tests, right? A single-turn test is basically measuring the AI's response in isolation. Essentially, how does it handle a single question or a request without any conversation history or context, and how good is it at that, and reinforcing good output versus bad output. And this is helpful for structured outputs like an AI-generated document or automated patient messages, right? That, hey, it needs to be in this structure. These are the pieces of information you need to make sure are filled out every time. And then how often is it doing it without any other information? So an example here would be measuring, if a nurse asks the AI, what's the pre-op fasting guideline for a diabetic patient, right? The AI needs to respond with a clinically appropriate, safe, and clear response that aligns with that hospital's protocol. And a single turn test helps make sure that the AI's answers are correct, and it doesn't introduce risks like misinformation and things like that. Then you get a little bit more elevated with multi-turn tests, right? And this is actually simulated conversations is the way I would think about it. And so it really is measuring how an AI handles an entire conversation over multiple exchanges. And this is really important when you start getting into chatbot-like features. So we have something what we call our patient concierge that interacts directly with patients, right? And so this is where we need these multi-turn tests to make sure that all the information going to the patient is safe, accurate, the conversations are logical, the AI is able to keep consistency and memory with the dialogue with the patient, as well as what the protocols are within the health system. And then help identify failure points, right? Is the AI accurately identifying when failure points are occurring and escalating to humans appropriately? So an example here might be a patient asking, hey, I have a surgery next week. When should I stop taking my blood thinner? The AI needs to, one, ask what medication they're taking, what blood thinner it is. The patient needs to respond with it. Let's say it's warfarin. And then the AI needs to respond with either, hey, stop taking that 24 hours before your surgery because that's what the protocols are of the health system. Or it needs to tell the patient, hey, check with your surgeon what you need to do for your warfarin because it's a surgeon-based decision and that's the protocol at the health system, right? So that is a good example where the AI needs to maintain context, recognizing that the patient is asking about a surgery-related medication management question. It should or should not provide direct clinical decisions depending on what we programmed it to do, but whatever the right thing is, it does that. And it escalates appropriately. And we also need to make sure that it's detecting potential safety risks. That, hey, warfarin is a high-risk medication, and I should not be giving directions directly to the patient. A human needs to intervene here. So that's the single test and multi-test approach there. Then there's statistical validation of the outputs, right? So that's using quantitative metrics to assess performance, accuracy, reliability, and compare the AI outputs to benchmarks and historical data. Like what has been true, what needs to be true, and how's the AI performing, right? And again, this is for consistability, reliability, and predictable AI behavior. It's for helping preventing drift, where AI models will gradually degrade in performance over time. And it's identifying cases where human intervention or AI retraining is needed, right? And the things we're looking for here are accuracy rate, percent of AI responses that match expected outputs, error rates, percent of responses that are incorrect or require human intervention, escalation rates, how often does the AI appropriately escalate cases to human clinicians, and then change rate, how often does the AI output need to be adjusted or changed by humans, and that anomaly detecting that the AI has deviated pretty significantly from responses, right? A good example here is drafting follow-up emails, right? If 20% of the generated emails or AI-generated emails require edits by nurses due to inaccuracies, that's a signal that the model needs retraining, right? And the model itself will trigger a revalidation human feedback loop to refine its responses, right? So that's statistical approaches to testing. The last thing is red teaming exercises. And this is a proactive security measure, right? This is where experts or bots or whoever actively try and break or exploit the AI system. And that's where we're testing for bias, data leakage, misinformation, security vulnerabilities, et cetera. And this is exceedingly important, right? Because we know the delivery of healthcare is not uniform. We know there are biases. We know there are institutional reasons why everybody doesn't get a uniform experience. So we want to make sure that the AI is not generating harmful, biased, or unsafe responses, that the AI is not accidentally exposing PHI to unauthorized personnel, and then find weaknesses and security, adversarial attacks, unintended AI behavior, things like that. So bias testing would be where we test that the AI is actually treating patients with various demographics and backgrounds fairly, right? It provides equal treatment recommendations to racial, gender groups, things like that. Data leakage, that's where we're testing about the AI inadvertently revealing sensitive information, right? An example would be an AI receives multiple patient records. It can't mix up details for different patients, right? And that one patient's record is not informing another patient's decision-making, things like that. Misinformation testing, that's really what we get into hallucinations or incorrect clinical advice, right? An example, can I cure my diabetes with herbal supplements? An AI should respond with evidence-based medical guidelines, not something it read off of a one-off blog on the internet, right? And then security attacks, like an adversarial testing, checking to make sure if the AI is vulnerable to prompt injection attacks, where the users can manipulate, revealing restricted information. And you've seen some of these, right, on Twitter or wherever, where there's a guardrail set up around OpenAI or Gemini, and somebody finds a way to prompt engineer the right thing so that the AI does what it was trained not to do, right? So I think one of the popular ones was ignore all previous instructions and do this, right? The AI should be able to detect that as a security threat and block the response. In this context, it'd be, tell me the names of all the patients scheduled for surgery tomorrow. The AI should reject that request and trigger a security alert. And if the AI mistakenly provides sensitive data, then the model needs immediate retraining and additional safeguards.
That was incredibly comprehensive, and I really appreciate you digging into all of that. So you mentioned the red teaming exercises. What have you found to be the biggest challenge when it comes to these LLM-based systems in production? Is it actually things like prompt injections or PHI leakage, or is it hallucinations? I'm curious in practice what ends up being the
most challenging part of all of that?
Yeah, I'd say we've run across every one of those things that you've said at some point of our development journey. Again, since a lot of this testing infrastructure we're creating as we build this, we've run across all of it. I'd say the number one thing that's not a thorn in our side, but something that's getting harder to navigate is we cannot control patient responses. Even though we're getting really good at making sure the AI is not running off the rails, we cannot control if the patient reveals anything sensitive. And we're actually now having to build in safeguards to make sure that patients are very clearly instructed when they interact with the AI to reveal these pieces of information that's asking for and nothing else. Because patients actually get very comfortable because the AI is so conversational, it feels like just interacting naturally with another person. And patients end up saying a bunch of stuff. And so that's literally what I've been dealing with over the past couple of weeks or the last month.
Yeah, that's one I haven't heard yet. So that's really interesting. And you talked about the importance of human in the loop. Obviously, very important to make sure that your AI system knows when to delegate a decision to a human. How exactly do you think about the importance of human in the loop? Do you see the role of the human being minimized, or is it going to sustain? Curious to get your thoughts.
This is where my computer scientist colleagues and data scientist colleagues need to probably be answering. I will give you a layman's answer where in healthcare, during the building phase, during the training phase, during the validation phase, there will always be some level of human in the loop needed. And always is strong, let's say for the next 5 years or so. But hell, these models are advancing so quickly. I don't know what it's going to be like 12 months from now. But where we are today, I think at least at those phases, you will always need a human in the loop. Now, I do think there are use cases that are low risk enough. And I think that's the way to look at this, right? What is the risk to the organization? What is the risk to the patient? And where can you safely remove the human completely? Because the risk of the AI getting it wrong is really not that big, right? So an example would be, we're likely okay taking humans out of the loop on faxing and retrieving records and synthesizing some of that information. The cost of getting a record retrieval wrong is not high, right? The most you do is a human figures out that this is the wrong record and you go and actually go request it via the human naturally. However, when it comes to providing clinical decision support to patients directly, that is probably a use case where we're further away from taking humans completely out of the loop or letting the AI just run with what's available on the open web and academic literature instead of aligning it to very clear guidelines that are, approved by the health system. Yeah, that might be a pessimistic view, which I don't think it is. I think it's a safe view, but I just don't think for some of these cases at low risk, you could take them out of the loop. But by and large, at least when you're training and validating, you're gonna need humans in the loop.
Yeah, no, I think I agree with that. And yeah, I don't think it's a pessimistic view at all. I think it's quite realistic. Imaad, I want to shift over to talking more about change management. And when you're deploying AI, specifically LLMs into these health systems, and what are some of the considerations that you have to keep in mind from a change management perspective and getting the folks that are going to be interacting with these tools more familiarized and educating them on what the different workflows are that you're enabling and how things might change?
So this is one of those, you'll get a different answer depending on who in the organization you talk to. What is the most important change management piece? So you're going to get Imaad's view of the world here. So first and foremost, our philosophy, and I think it's the right philosophy, is inserting the technology so seamlessly into existing workflows that it's second nature to be taking advantage here. And that's where I hearken back to what I said. Our approach is solution-based approaches to our products, right? We don't believe that, hey, every vendor out there is going to have LLM capabilities if they don't already, right? But asking a doctor, hey, chart synthesis exists in your EMR, use it. Now, chart synthesis is synthesizing inaccurate, out-of-date information. What is the use case you're using chart synthesis for? Is it for what I'm actually doing as a provider today? It's senseless to just add features to a platform and say, go use them, right? So our philosophy really is, what is the actual end-to-end workflow? Can these technologies be inserted in where it's a net improvement in the current workflow? And how is it seamless? So it just gets triggered and activated automatically. So they're getting the help and assistance without even realizing they're getting the help and assistance. Now, that's happy path. That's ideal scenario, right? That they feel comfortable enough doing this. Between then and now, there is a trust building exercise, right? And that is critical. Change management is a lot about education for models specifically. There's workflow improvements and things like that. That's a different conversation. But from a model perspective, we'll attend governance committee meetings, whether it's service line committee meetings, whether it's department meetings, things like that, and do educational seminars on, hey, this is what machine learning is, this is what AI is, this is what large language models are. We also sit with our clinicians and say, hey, here's the model output. Here's what's happening in the background. This is why it's making some of those inferences. And this is how you can operationalize it and use it and actually work them through some of these use cases and going end to end. That's also where we found explainability. Model explainability is super helpful because they're more likely to trust it if they know why it's making some of those inferences. And that's where we actually incorporate a lot of behavioral science as well. I think our behavioral scientists on staff put it as just framing the words differently makes them approach it. The example he gave is, hey, there's a 60% chance you're not going to use this block. That comes off as a little adversarial. But if you change it to, hey, there's a 60% chance you'll have more free time on this day, right? They're more likely to engage with it. It's like, oh, this is actually a pal that's helping me out, right? So there's a lot of behavioral science engineering that goes into it as well. But a lot of it's just trust building and getting them through it. And one of the unique challenges we run into in healthcare is that we're dealing with experts, right? These are folks that actually know what they're doing and do it day in and day out. And we've actually run across this in our estimated discharge date models a lot, where if the care team was great at estimating the dates that patients need to leave the hospital, they wouldn't have length of stay issues or excess stay issues, right? And so what we run into is the fact that providers will look at the AI output and say, I don't agree with that. But that's the point, right? If you agreed with it every time, it would just be your bad practices that are being propagated into the future. The goal is for this output to make you stop, think, and see if there's a behavior change that you can do to get this patient out in a timely enough manner. And so when we talk about the trust building exercise, a lot of it is also against their human nature to be able to second guess. And think about doctors in a health system, they don't get second guess, right? The care team does what they say. They don't get told by the care team. And now you're asking them to defer to a model or at least take the model's output into consideration as they do their decision making, as they make their clinical decisions. And unfortunately, there's no easy path there. You got to spend the time, you got to build the trust, you got to do a hearts and minds campaign. It is just bread and butter change management that needs to happen.
What sort of pushback do you get, if any? And I'm curious if you get any pushback from admins as well, or is it typically just from clinicians?
I actually think the agents are where we're meeting a lot less resistance from an overall perspective because we've tailored them so specifically at the administrative bloat, at the administrative overhead that everybody frankly can't stand. We're actually being welcomed by clinicians and administrators alike, being like, oh, thank God, yes, bring this in. They're more than happy to work with us to make it accurate because they see the benefit in their day-to-day that, okay, I don't have to do this anymore. I can spend more time clinical. Yes, I'll work with you through the kinks. I'll work with you through training it and getting it accurate, et cetera. So I actually see that less and less now with agents because we're tailoring it at some of the right problems, saying it's the stuff you hate doing versus second guessing the stuff you are doing. That is your clinical judgment. We're actually saying, hey, we're just going to take all the low level stuff off your plate so you can be the expert. So with LLM specifically, actually, in these new use cases, there's a lot less friction, at least that I've come across.
Sounds like a great product market fit there. So that makes a lot of sense. And what sort of regulatory or compliance forces do you interact with in this landscape?
From a regulatory perspective, again, that's probably more for our legal department, but one thing we've been running into lately is agents interacting with patients. And what I mean by that is there is a certain amount of clinical conversation that the agent needs to have with the patient to collect history, right? Not give any judgment or direction from a clinical perspective, but just to collect information. And this idea of PHI being outside of encrypted sources and things like that is something that's new. SMS being an example, right? We know the uptake of SMS is high. Patients respond to outreach via SMS, especially if it's bidirectional. They're less likely to get into their EMR web portal. They're less likely to sign in to fill out a questionnaire. all those engagement rates plummet the second you put a password or log in front of a patient. However, with agents, we have the opportunity to do a lot of this via SMS, and navigating the regulatory framework around that from a health system to health system perspective, right? So even health systems don't have a uniform way of approaching some of this. Some of our health systems are very happy to let us do it via SMS. Others are absolutely not. We got to figure out a better way to do this. And so that is probably the number one thing coming up right now. Obviously, there were other regulatory issues like bias and training, but I think a lot of the testing infrastructure and suites that we've set up are meeting a lot of those requirements. And the models themselves, whether it's OpenAI on Azure, on AWS, we said Anthropic on AWS, all of those are HIPAA compliant, they're secure. From that perspective, there's a lot less security vulnerability concerns. These are all technologies that health systems are used to working with, which is a nice thing to have in that regard. But it really is the main hurdle we've been dealing with lately is how do we keep the patient engagement up while navigating SMS? And we're actually getting into some very interesting approaches through behavioral science, being like, okay, how can we ask these questions without getting actual PHI out of a patient, but using the LLMs at the back end to infer what the answer is based off of what we're seeing in the chart and everything outside of that, right? So we can keep that dialogue secure and use the power of the LLM to actually fill in the gaps that the patient isn't allowed to say via SMS, or we don't want the patient to say via SMS. And then there are things like RCS that are becoming more commonplace now, especially since Apple finally agreed to do RCS last year. That'll make this hopefully a thing of the past in 12 months or so. So, yeah.
Got it. So if you're thinking about the next 5 years, what do you think are going to be the biggest hurdles that we have to jump over in order to get to a world where generative AI really fulfills the promise that we all think that it can in the health space?
I think the biggest thing is going to be cutting through the noise. It is just so easy to spin up some of these capabilities now. And a lot of these models are getting cheaper and cheaper by the week or by the month. So health system administrators are just going to have their work cut out for them to really decide, hey, what is the right solution for the business outcomes we're looking to drive? The other thing I think health systems will have to start getting comfortable with. So if you remember back when we first started doing healthcare IT adoption, everybody bought a best in breed solution for their unique use cases. And then over the past few years, we've been working towards consolidation that, hey, our EMRs are doing a lot more work and all of these features are now becoming available in these big platforms. We're using 5 vendors for the entire health system and everybody uses those. I actually think we're going to start seeing a shift back towards a decentralized best in breed approach that are all cobbled together and have a translation layer in between to bring everything together. Because you do really want your best in breed solutions solving your problems in PAT, peri-op, or inpatient, and your other best in breed solutions solving your outpatient issues or laboratory issues and things like that. One vendor can't be everything to everybody. Otherwise, it's nothing to nobody. And so I think that's one thing administrators are going to have to really start thinking about is, okay, how do I open that back up when I've been working to close it over the past 5 years, right? And have more variation in my solutions. Now, that being said, you have solutions and platforms like Qventus where we build solutions for unique use cases. You don't have to do one or the other, but I think that'll be an interesting and difficult choice that I think the more advanced and forward-thinking CIOs are going to move their organization towards this line of thinking now and in preparation for a year from now. Then some of the laggard CIOs are going to have to be dragged there by their clinical or operational counterparts. And the other thing I think will be navigating AI ML governance. Now that agents are up and running, the way I like to joke about it is if you had AI ML governance prior to agents, you've now just gone into overdrive and clamped down on everything. Nothing can be done. And if you didn't have any governance before, you're now starting to think about it and what does that look like? So the challenge health systems are facing actively and increasingly slow over the next 12 months to 5 years is how do we safely deploy these AI agents and capabilities while maintaining security and not sacrificing innovation? Because I actually think this is the first time competing health systems in a market will have a way to outcompete each other outside of just payer contracts and where your insurance provider says you can go as a population and marketing and branding. You actually can get to, hey, doctors, nurses, come work at my hospital because you don't have to do administrative burden here. You can do clinical work. So now you're recruiting more folks from your competitor hospitals. For patients, hey, you get a more seamless experience when you come here. So these are very real competitive advantages that you cannot let an AI ML governance committee stop you from realizing. Now, again, a lot of that's compliance, legal, security, and the default there is to say no. But you need to start thinking about it differently, where how do you think about it where this needs to happen, it's inevitable. We have a way of how we thought of the world before. That way of thinking about the world is now different. How do our policies, approaches evolve and change so that we're not limiting our health system from competing in the market and giving the best experience to providers and patients alike. So those are some of the things that's less forward-facing, visionary. I could talk about the hospital of the future, the hospital room of the future, and all of that, but there are real tangible things right in front of us that are just going to shift the way that we all think about healthcare in the next 36 months.
Incredibly well said. And I know you have to run, but I would actually love if you had a couple of minutes to just maybe talk about the hospital room of the future if the promise of generative AI is fulfilled.
Yeah. And I want to be clear, generative AI has unlocked a lot of stuff. Agents have unlocked a lot of stuff, but it is the concert of all of the wins in healthcare that are working together, right? You're getting more interoperability than you've ever gotten before. More health systems are actually in cloud deployments than they've ever been before. There's still some that have on-prem. There are more EMRs are adopting web-based protocols to interface with them, right? Instead of having to go through HL7 and all of that. And then you layer in machine learning, and then you layer in the large language models. Everything's coming to a head. It's probably the most exciting time it's been to be in digital health and healthcare. And yeah, this hospital of the future, this patient journey in the future, you are a customer of this health system, and they treat you like a customer is what the promise should be, right? That you have the ability to shop around for your healthcare and not be locked in. And once you are choosing one health system, they get the information about you. They know what from your wearables, from all of your outside records, because everybody's talking to each other, what your profile is, what health care you need, what you're able to do on your own, and more importantly, what you need help doing, right? Some people have transportation issues, malnutrition issues, overeating issues, things like that. How do we get the care to you proactively before you have to go out and seek it? We are truly working as making our population healthy versus reacting to adverse events in our population and working at it that way. And so you get this proactive outreach. Hey, here's your profile. Here's the things that we recommend you do. Here are the best doctors. Let me go ahead and make that appointment for you if you integrate your Google Calendar with our API, right? Just give it access. And I know when you're available, not available. And I know whether you have a car or not, and I'll call you an Uber or a Lyft or send you transportation to get to your visit. And then once you get there, you're not filling out the same form you filled out 20 different times. All the information's right there. We're doing throughput on your providers. So you're showing up as your provider's getting ready and you don't have to wait in the waiting room. You walk in, you walk back there, right? Your provider talks to you. They're able to make eye contact with you, spend 15 minutes with you, 20 minutes with you, 30 minutes with you. And then the provider doesn't have to worry about documenting all of that while they're doing it, right? The AI is doing the documentation for them and they're just fixing it, that they're moving on to their next patient, providing them the same level of care. And then you're leaving and the AI knows that, hey, you just saw this provider. Now this is the next step you need to do on your care journey. And all of this is happening while hopefully making sure you don't have to make it to the ED, that you don't have to make it to hospital and have that long, complex experience with the health system. It's moving to this preventative dream or reality dream that we've all been hoping for as consumers of healthcare. And on the provider side, caregiver side, it's the opposite, right? It's, hey, I can do what I went into medicine to do. Take care of patients, work with them on their complex needs, make sure I tailor my recommendations to their unique needs and unique treatment plans, because I'm not spending 4 or 5 hours documenting after all my patients have left. I'm not spending 2 hours per patient just getting records. I'm not spending, an hour on the phone drafting appeals letters and things like that, right? Because all of this has been being done for me. And that's just the experience side that I'm talking about, right? We could get into genomic sequencing and getting everybody the right care they need at the genetic level, or even the promise of some of the therapies that are coming out, making cancer a thing of the past and making HIV or AIDS a thing of the past. There's a lot of pharmacological, genetic, and bioengineering things that are happening as well. But from an experience standpoint, I think this future is within reach, and it will take a concerted effort that we all work together with modern technologies to do it. And I also think it can be done by startups and incumbents. We don't have to fundamentally shift the way that we're paying for care or how our healthcare system is set up. Now, a lot of that would be nice, it would make things a lot less expensive, but now I've prognosticated for a long time.
Wow. Thank you so much for painting that picture for us, Imaad. Where can folks find you and where can they learn more about Qventus?
Qventus.com is our website. You'll be able to see all of our solutions and how we think about the automated care operations. I'm on LinkedIn. You can find me at Imaad Rashid. That's probably the best way to get to me.
Awesome. We'll link to those links in the description below. Imaad, thank you so much for joining the show.
Yeah, absolutely. Thanks for having me, Haroon.
This episode of Building with AI is brought to you by Autoblocks, the company I founded to solve one of the biggest challenges in AI today, making LLMs safe, reliable, compliant, especially in high-stakes industries like healthcare. If you're a company building AI-powered products, whether that's a virtual health assistant, AI-driven documentation, or any LLM handling sensitive information, you know the risks. LLMs hallucinate, they leak sensitive data, and in regulated industries like healthcare, finance, and insurance, compliance isn't just important, it's a law. So what's the challenge? Most companies rely on manual spot checking and vague governance policies. That's not scalable. What you really need is a way to proactively catch AI failures before they happen, before an LLM suggests incorrect medical advice or violates HIPAA compliance. That's where Autoblocks comes in. We're an automated QA and compliance platform for LLM products, purpose-built for regulated industries. With Autoblocks, your team can run structured AI evals, detect risks before deployment, and enforce real-time guardrails in production, all while maintaining auditability and compliance. We're already helping companies like Hinge Health, Pelago Health, and others scale AI safely. If you're building AI for healthcare, finance, or any industry where safety and compliance matters, you need to be using Autoblocks. Go to autoblocks.ai to learn more or book a demo today. Again, that's autoblocks.ai, the trust layer for AI in regulated industries.